him and your case, please.
Welcome to SNU Hospital Cath Lab. I'm H.S. Kim. My co-operators are Dr. Han-Mo Yang, Dr. Jung-Gyu Han, and Dr. Ji-Hoon Kang, and all staff members. Okay, let me introduce my first live case. Slide, please. Okay. 86 years old female received PCI to OM2 for unstable angina 2 years ago. She was okay, and she has suffered from dyspnea since 5 months ago, functional class 3, and severe AS was confirmed by echocardiography. Next. Age 86 years old, octogenarian, definite candidate for TAVI. Small height, but BMI is okay. She has 2 important previous history, PCI, in other words, CAD, and CRF, but not on dialysis. In our TAVI registry, there are 2 important risk factors, presence of CAD and ESRD on dialysis. Next, several medications, and target is severe AS with TAVI. As this score is more than 10, definite high surgical risk patients, plus X-ray, okay. ECG shows PL interval is a little bit prolonged, plus AV mean pressure gradient is 65 total with AVA 0.7 square centimeters, a little bit higher pressure gradient because her LV function is best. Ejection fraction 65%. Plus, coronary angiogram shows OM2 patent for 2 years, and LCA unremarkable. RCA was also unremarkable. Abdominal aorta or CT shows a tortuous aorta, and especially there is heavy calcification on iliofemoral artery. And the heart position is horizontal. That favors SAPIEN system than Evoltal. Plus, cross-section of aortic annulus, mean average diameter is 21.5 millimeters with balanced calcification through 3 leaflets. Good sign. Plus, ST junction is more than annulus diameter, 25. Good sign. Plus, coronary height is 16 millimeters. Good sign. Plus, right iliofemoral artery CT shows calcification in the iliac artery. Plus, minimum lumen is 6.2. That is a little bit hurdle for SAPIEN system. Plus, left iliofemoral artery more heavily calcified. Plus, minimum lumen diameter is 6.0, narrower than right side. Thus, we chose right side as a main route. Plus, to summarize the measurement, annulus diameter 21.5, ST junction more than that 25, height of coronary ostium 11, 10, 13, and annulus area 340. Next. 340 corresponds to SAPIEN 323 millimeter valve with nominal volume 20% oversizing. In this case, I tried to just 0.5 cc on the field with 16% oversizing. I prepared 3 issues. First, which device is ideal for these patients? I think any device would be okay for these patients. But risk of AV block, and considering horizontal heart, I chose SAPIEN 3 system for this. It is not absolute. We can do Lotus and Evoltal for these patients. Plus, second issue is, how about the current risk stratification system for TAVI? Conventional model is SDS score or Euro score. but that is based on the patients who undergo surgical AVL. So that underestimate surgical risk at higher score, but that does not include frailty or disability, such as gait speeding, daily living, daily activity. That is also a very important factor, but it is not included in STS score system. Thus, even though low score in the STS scoring system, if the patient has definite frailty or disability, we can do TAVI. That's the rationale for us to do TAVI in low surgical risk patients. Plus, so we need better prediction model in traditionally low surgical risk patients, including frailty and disability markers such as low BMI, COPD, liver disease, coagulopathy, and others. Because these factors are important risk factors in TAVI trials and registry. Plus, the third issue is converse aspect. If we do TAVI, the patient dies soon, we don't have to do TAVI. Futility of TAVI. COTS indices include 6 factors: independence in feeding, bathing, dressing, transferring, toileting, and urinary incontinence, and independence in ambulation. So if the patient is associated with such kind of inability, we don't have to do TAVI because the patient soon die, even we perform TAVI. But in these patients, she is really independent in feeding, bathing, dressing, transferring, toileting, no urinary incontinence, walk very well. Thus, we can expect a really great benefit after TAVI. Okay, let me show you the progress today. Angel, please. We always puncture the femoral artery under guidance of fluoroscopy. Plus, as we expected, calcification in right iliac artery is a hurdle. Thus, we were not able to advance sheath. Plus, in this case, we usually perform a bugination with narrower dilator. Plus, first, 16 French dilator, difficult but passed. Plus, then 18 French dilator, because external diameter of sheath is 18 French. A little bit difficult, but
What wire
twice.
did you use, Dr. Kim? Is it a
Safari.
Lunderquist or a super stiff?
Safari.
Okay.
Then plus, 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 minus. We were able to pass the shears. So bugination is a little bit a convenient strategy to widen the narrowed calcified iliofemoral artery. Then we perform a root arterography to make sure the best angle. The recommended angle from company is not good. Plus, then I found LAO 25, caudal 15 is the best angle. Plus, okay, this is the progress that we achieved today. Is there any comment from the panels? I just
Any
continue
comments
the
or
process.
I wanted to say before you showed us this that just as you said, both valves could be perfect for this case. The only thing that would make me choose an evolute in this case was the periphery, Because whenever it's borderline, I think that one of the advantages of Evolute over Edwards is the profile in crossing the narrowed iliac or femorals. And in your case, the point that you were stuck with the sheet was a point that sometimes if you take the sheet back and rotate it, it can cross because, you know, there is this niche that sometimes hit a piece of calcium and then it's stuck. But you did it very well. But any more comments from the audience?
Maybe an Amplaxer super stiff wire might have made it a little easier.
That's why I asked him what.
And I think it was an excellent choice that you chose the right side because the left side had circumferential calcium.
Yes.
So I think they did a really great job. I think it's good.
Right. But Lunderquist could make his life easier. You're right.
Life easier.
Yeah.
I'm Dr. from Korea University. Just one question. In your experience during last series of your TAVI study, the PR prolongation is also risk factor for high incidence of a block after TAVI. You consider
Yes,
the PR prolongation? Just the first degree AV
If
block.
PR interval is prolonged, there is high chance of LBBB and complete AV block.
You know, we
It's
discussed this.
difficult to pass that.
We will let
Just
them work in the
artificial
meanwhile.
is 0.7, but it is difficult.
Which wire are you using now?
Thermal.
Which catheter do you use?
Straight to Rumo.
Straight
This is the
Amplux,
easiest
left
wire to
one.
cross.
This is the diagonal catheter. Which one do you use? It's AL1 or 2?
Yeah. You can see they're using L1. In the meanwhile, while they're working, you know, you raised the issue of PR prolongation. And you know, we had yesterday a session, I don't remember what it raised it, and there was such different numbers of pacemaker implantation in each center. And I'll always dictate that, you know, people are asking what is the strongest predictor of pacemaker implantation. And I say that the strongest predictor of pacemaker implantation is the electrophysiologist that works in your cath lab. Because there is no guidelines, nobody knows the truth, and I think that this is one of the truly unmet needs of TAVI today, to dictate the real risk of complete AV block and the guidelines to permanent pacemaker implantation. What do you think?
Dr. Finkelstein? Do you prefer using a thermo wire to cross? Because
Yes.
I feel it can get caught up in the cord.
no.
I usually like a spring, the normal chip.
Well, you know, I've tried them
Rumo?
all, and I think the straight to Rumo, but the stiff straight to Rumo.
Yes.
You know, there is the soft one
Yeah.
with the blue
Yeah.
and the stiffer with the brown one. So the stiffer straight to Rumo, I think it's the
Is there
easiest one to
stiff
cross.
thermal? Stiff thermal? 왜 말을 안 듣나 너희들은? 제이트밖에 없어.
That is
You
the
don't
usual
have
time
straight
limiting
thermal.
factor.
Yeah, it enter. 저장. 저 아래요.
예, 말씀하세요. 말씀하세요. 네네.
We don't have straight, strong, stiff thermal. Just J tip.
네, 알겠습니다. 네네, 알겠습니다.
Okay.
This is definitely a case that I would rather do a predilatation.
Predilatation, yeah.
The way I saw that
wire.
it's difficult, not the wire, but
implant.
the AL1
So I
was difficult
I
to introduce in the
changed the
ventricle.
catheter into pigtail in LV.
This is one of the signs that
Okay.
you should do a predilatation.
I think the valve area was 0.4, so.
Yeah.
education point is freely pass the guiding catheter.
Are
It's,
you
it's,
going
the
to
sign
perform
of our
predilatation, Dr. Kim?
No,
Oh.
because my personal strategy is if the AVA is less than 0.5 square centimeters, I perform predilatation. But if it is more than 0.5, then I usually skip predilation. Of
Yeah,
course, sometimes it is difficult to advance the sapien system, but let me try without predilation.
Now, the impression I have is that it was pretty difficult to introduce the catheters through the orifice of the aortic valve, and this is one of the signs that I have not to take a chance. And you know, it's much easier to take a chance with the volute and not with Edwards, because in Edwards it's very difficult to withdraw back. And then you have to put him on a parking line
We can show you.
on the side and
The
then
double
go
tracing.
from the other side with another 12 French and do predilatation, and it's a mess. What do you say?
We are going to show you the double tracing of LV and aorta.
Dr. Kim, this is Dr. Her speaking. And even the bicuspid valve, you do not perform the predilatation in the more than 0.0 millimeter scale?
Yeah, that's a good question, because it is always difficult to do a proper valve size in bicuspid. Thus, if it is ambiguity, I fully recommend you to do a predilatation and see the dye leakage from aorta to left ventricle. If dye leaked, then you can choose a bigger valve. If dye does not leak, it fit well, then you can choose a smaller valve. Thus, for this purpose, I perform predil, but the size is very straightforward, then I skip the predilatation, because actually the stroke incidence is higher in bicuspid AS after TAVI than tricuspid. That may have some several factors why there is higher stroke incidence in bicuspid AS after TAVI is more frequent predilatation and more heavily calcified dirty debris on the aortic valve apparatus and younger age. Thus, minor stroke sign may be more vivid than elderly patients. Thus, I expect such kind of three factors may explain the higher incidence of stroke after bicuspid TAVI. In this context, I try to skip predilatation even in bicuspid TAVI.
That's a very, very important point. Very well put. By the way, while you are working, I want everybody to notice the pressure tracing shows now that either the patient has some kind of AI, but the diastolic pressure in the aorta goes pretty low. And I'm looking at this every time because at the end of the procedure, even if the result is perfect, there is kind of so-called memory that will still show a lower diastolic pressure in the aorta, and the AI index will not be very good, even if the result will be perfect. So notice that. The AI index has got some limitations.
Okay, we are now just before to insert the TAVI system. Thus, if you go over Samsung Medical Center, then I will show you the real the feature of implantation of sapien 3 in these patients later.
Okay, we're waiting.
Is Samsung not prepared yet? MC가 넘어간다고 하더니. Can I progress further?
Yes, of course, we're waiting.
Okay. I insert suffering wire into left ventricle. Okay. I prefer the RAO view when I insert stiff wire or pigtail and soft wire into left ventricle. It is safer and is easier to localize the device into apex. Then I change to best angle or AP. Oh, valve is already prepared. Okay. Okay. Valve, please.
There is one important point to take care of while you are working. Sometimes when you introduce a super stiff wire, you see that the blood pressure goes down. Now, every time it makes you like be worried. That's good. But the main reason for this is what we call the vagal effect. If you go into Google, write aortic arch, you will see a beautiful picture of the aortic arch with a lot of red dots on the roof of it. And those dots are vagal tone receptors that the super stiff wire is touching and creates a lower blood pressure. It means nothing. Just wait a little bit and it will pass.
Also, there can be some hemodynamic instability because of the AI, because of the super stiff wire.
Sometimes, yes, of
Yes.
course. This is another reason, but I think that the main reason
Is
is what I mentioned, because the AI remains
Same.
all the way, but this vagal tone is transient.
So, LAO. I advanced the whole system through aortic arch. In this case, I prefer LAO view. Then turn to best angle, LAO 25 and cover 20. Coaxiality of stiff wire is good.
Very well.
Wire steady. Okay, well passed.
He was right.
If it required, we can prolong the life. So I remove the pushy catheter.
This is something that should not be forgotten.
자, test it. Angle is good, and depth is also acceptable. 자, cine. I should. Okay, good. Then, rapid pacing.
Dr.
pacing
Kim, I have a
test.
question. Why don't you put the pictal much lower in order to visualize everything? I mean,
Yeah,
my
it cannot
my
advance.
eyes are older, you know.
You cannot do that, just thermal. Because it's very torturous. There's
So
pigtail.
use a
Cannot
supracore
advance.
wire in order to put it down. I mean, you cannot appreciate exactly where you are. I mean, it looks okay. I think that you are like 2 millimeters too high, but that's okay.
No, I advanced the pigtail with guidance of
Good.
Good.
thermal. Still, it's very difficult.
Look, if the patient is stable, why won't you change it to a supracore wire or any stiff wire in the pigtail, and it will enable you to go down. I think, I'm sorry to bother you, but I think it's very important for the audience to see exactly how you are implanting. What do you think? I mean, do you agree with me, Podium? I mean, I'm the bad guy here or what?
It's very difficult to advance the pigtail.
Doesn't want to listen. What I sometimes do is I just put the stiff end of the wire halfway up the pig, and then it helps move it down.
Once again, dye, injection. 안 보인다, 그냥. 좀 마운트 좀 많이 해봐. 자, 다시 쓰네. dye injection. 슛. We can see the intermingle of the two catheters. That's the reason why it is difficult to advance pigtail. Just
Of course.
shoot. It's okay.
It's okay. And as a matter of fact, you see the line of calcium that enables you from the previous injection to know exactly where you
자,
are.
rapid pacing. 다이 준비하고요.
다이 준비 안 됐습니다. 좀 있습니다.
오케이. 다이. Inflation. 4, 1,000, 2,000, 3,000, 4,000, 5,000. Deflation. Pacing off.
Beautiful.
Okay. Pacing rate 좀 올릴까요?
One of the other things that should be noted, that I don't know why, but in Edwards implantation, the recovery of the blood pressure takes more time than in other valves. Did you notice that?
Y 좀 넣고. 오케이.
Have a look. It will recover.
Yeah?
It just takes time, yes.
오케이. Just angio. angio 준비. It looks good. Okay, we can show you a TEE. Stiff thermal.
You see, it takes time and it recovers. Slowly but surely, you see?
Dr. Jiwon Kang, would you please show the
Nicely
Yeah.
implanted, and using color,
Yeah.
we can see very minimal suspicious AI, which I will change to the short
Yeah.
axis.
네. 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 알겠습니다.
And this is the short axis view.
Yeah.
We can see all three cusps are opening well. And in the color view, using the simultaneous view, we can see that there is very minimal AR.
Even less than minimum. You're right.
Because we performed about 15% of our sizing, a little bit big. Thus, that's the reason why there is a transient, no AV block. That's the beauty of Sapien 3. Of course, I implanted a little bit high. So I think the bigger, the better, if safety is guaranteed. Thus, my personal practice is I try to get highest possible oversizing index. So in this case, 15% oversizing is a little bit big in case of Sapien. My personal favorite oversizing index is about 10% or 20% in Medtronic Evolutor.
Dr. Kim?
It is very difficult to advance
Dr. Kim?
detail. Thus,
Yeah.
I will show, yeah.
Dr. Kim?
Okay.
Waiting you.
Yeah,
Okay.
let me
You
show you
summarize it,
the
yeah.
final process. Angio, please. Angio switch. Okay. This is the scene when I perform implantation of sapien valve. As you can see, I target a little bit higher because I can see that oversize index is a little bit much. Thus, I perform underfill. Underfill means there is a less shortening of lower half of sapien valve. That requires higher implantation to maintain AV conduction. That's the reason why I target a little bit higher, well described, well shown in angiogram. Plus, the immediate aortography, I always do immediate aortography to see kind of catastrophe or not. It's good. Even though there is a stiff wire, regurgitation is minimal. And echocardiography, TE-wise, there is no paravalvular, pinpoint paravalvular leakage. Thus, I switch to pigtail catheter plus. And once again, perform angiography is acceptable, trivial. Then we can show you the TE image. TE, switch to echo.
Yes, this is the TE images as a 3D, and because of the alignment of the axes, I'll show you a review that I did about 5 minutes ago. And we can see in the upper left image that all three cusps are opening well. And this is a live image of the long axis again. And again, we can see that there is almost no AR index observable. And going to the short axis, this is the short axis. We can see all three cusps and also very minimal AR.
Just 11 o'clock pinpoint color. But we already performed 15% oversizing, thus it is not wise to do further pinpoint regurgitation at 11 o'clock. It's hard to see. It is not detectable when you see it through TTE. So conscious sedation status, you can estimate that there is no regurgitation, but there is a subtle regurgitation through TEE. Angio, please. Plus. Then I remove the ventricular catheter. This is another angiogram. We can see no regurgitation, a little bit transvalvular regurgitation, probably. I can see such kind of minimal regurgitation through valve because of the poor coaptation of leaflets immediately after implantation. Plus, then I change the angle to see the under-expansion of valve frame. It's good. Plus, more right angle, we can see under-expansion of right lower side due to eccentric calcification. That may be source of pinpoint regurgitation. Okay, then I will show you the real-time angiography, best angle AP, best angle. I always perform a tangential view. Okay, this is real-time angio. So, cine. Shoot. No paravalvular regurgitation. Then slide, please. My junior fellows made briskly the summary slides as shown here. Before TAVI, the peak pressure gradient is about 8 millimeters of mercury. At that time, AR index was 18, even though there is a minimal regurgitation. suggesting wide pulse pressure and aortic stiffness, well supported by severe calcification around iliofemoral artery and distal aorta. Thus, after TAVI, no pressure gradient, but still there is wide pulse pressure leading to still low AR index 20, but no regurgitation. So AR index is not perfect index to measure the regurgitation. It is confounded by aortic vascular stiffness.
Yeah, this is what we
Plus-
said before the procedure, if you remember. That's kind of memory as well. And if you are going to take this, if this patient will undergo another cardiac catheterization within 2 or 3 months, you will see that the AI index will be perfect, much more than 25.
Okay.
What do you say?
Then how about PR interval, pre-TAVI, 230 milliseconds, post-TAVI, 234 milliseconds. That is beauty of SAPIEN 3 system. Plus, thus, to summarize this case, there was first issue, iliofemoral calcification. That is really give us a hurdle to pass the shears. There are several ways to overcome such iliofemoral calcific stenosis. The first one is lugination that we have shown today using 16 French dilator, or 18 French dilator, and then pass the sheath. The second one is, if it's not possible, just doing PTA. And then if there's that severe dissection, then after TAVI, we usually implant stent. AV regurgitation manifested by AR index, there is some pitfall. Thus, we have to consider several factors to assess the exact existence grade of paravalvular leakage. This is really a representative patients with high surgical risk, a really good candidate for TAVI. It's not difficult. It's very short duration procedure with wonderful results. No regurgitation, no AV conduction disturbance, no any problem, no hemopericardium by TE. Thus, really high surgical risk patients, TAVI is a representative standard treatment choice. But even in low surgical risk patients, ST score has several pitfalls, not include frailty or disability concept. Thus, we have to consider several deleted, not recognized factors in ST score, such as COPD, liver disease, low BMI, inability, frailty. And conversely, we usually perform a TAVI in octogenarian or even older than 90 years old. The life expectancy is not so long. Thus, we have to consider futility of TAVI. In this context, we have to consider CUT's 7 factors. The patients are independent in walking, feeding, toileting. Is there any urinary incontinence? If it is okay, we perform TAVI, even the patient's age is over 90. But if there is several serious independence, then we have to consider more conservative regarding the TAVI, because TAVI would be futile for such kind of patients. That's my personal message.
Well, I think
Okay, Andrew, follow Andrew.
I think it was exciting case. I think it was a beautiful result, but much more important than that, it was a real educational and teaching case. We have seen everything you just mentioned, and we thank you so much. I think we should move now to the CTO room, unless there is any more questions from the panel or from the audience.
Thank you, Dr. Kim, for the patronized educational presentations. Thank you.
Thank you very
Again.
much.
Thank you.
See you in the afternoon.
Dr. Han?
Oh, yeah, yeah.
Dr. Han?
Okay.